with the possible diagnosis of microvascular angina, because the arteries were normal on the previous angiogram, coronary artery spasm, whether epicardial or microvascular because of the angina at rest and nocturnal angina. There was also the possibility of plaque disruption and thrombosis, which may occur, or coronary dissection in a woman with those symptoms at rest. The tests that were planned was a stress echocardiogram, a cardiac MRI perfusion scan, and angiography with acetylcholine provocation for spasm and physiology tests, exactly as the guidelines recommend. The idea was that we wanted to know the anatomy, we wanted to see if there was myocardial ischemia, we want to see whether the ischemia caused LV dysfunction, and above all, we wanted to know the mechanism of ischemia to select the right treatment. So the arteries were still normal, there was no obstruction. When we injected acetylcholine, there was no spasm in the epicardial arteries, but the patient developed the usual chest pain and ST segment changes similar to the ones we saw in clinic. The administration of nitrates resolved the pain and the electrocardiographic changes. And this is a typical example of microvascular spasm. But in addition, and I think this is what caused her angina at rest, she did have a reduced flow reserve, which was assessed in the catheter lab with adenosine. And the flow reserve was reduced to 1.6 for a normal of up to 3, of a normal of 3. The cardiac MRI perfusion scan showed the presence of subendocardial hypoperfusion, which is compatible with coronary microvascular dysfunction. So these tests allowed us to make a proper diagnosis of the problem. So she was treated with anti-spasm treatment, amlodipine, 10 milligrams daily, in addition to the other medications that she had been given previously. At 3 months follow-up, the rest angina had gone away, but she continued to have very bad effort-induced angina despite good control of her hemodynamic situation. So because of the microvascular dysfunction seen at angiography and which was not resolved by the calcium channel blockers, we prescribed ranolazine, started with 375 milligrams twice daily, and then up titrated this to 500 and later to 750 milligrams twice daily. And we did this because of the evidence we have in the literature for ranolazine in patients with microvascular dysfunction, which I'm actually showing you on this slide on the yellow boxes. And when we reviewed her at 3 months, her exercise capacity was a lot better. He had restarted cycling and she only had occasional chest pain on effort at high workload, and her HbA1c was also slightly improved.